Okay, we are back. This is Senate Health and Welfare, May 9th, and we are looking at two bills that we have worked on quite a bit. Starting with 266, H 266. All right, welcome.
Thank you.
Do we have any changes? That's all the
same
one, 2.2 on.
Yes.
So why don't we go through that one last time, and then we'll hope that the fifth member of the committee comes in.
Okay. Good morning, Jen Harvey, Office of Legislative Counsel. I will put the language up on the screen. Okay, this is H266, an act relating to the 340B prescription drug pricing program. I don't know if you want me to just go how much detail you want, or you want me to just remind you what's in here.
Remind us what's in there, remind us what the 340B program is, just the highlights.
Okay. So 340B drug pricing program is a federal program in which certain eligible entities, so covered entities is what we call them, are authorized to obtain prescription drugs for a lower price through the federal program. This bill in section 1 adds a new subchapter in title 18, chapter 91, which is prescription drug cost containment. This subchapter is on the 340B drug pricing program. So we have 4681 is definitions. 4682 has various ways in which it prohibits prescription drug manufacturers or their agents from interfering with the use of a contract, a 340B contract pharmacy. So a 340B covered entity contracting with a pharmacy to provide 340B drugs to its patients who are eligible. And it is for 340B programs for outpatient drugs. No effect on Medicaid violations. There is a private right of action allowing the 340B covered entity, contract pharmacy, or anyone else injured by a manufacturer agent violation of the chapter to bring an action in court. And it specifies that nothing in this subchapter should be construed or applied to conflict with or be less restrictive than federal law.
The problem we're solving. So I may be reporting this. Is that hospitals and FQHCs, amongst others, can contract with a pharmacy to dispense their outpatient drugs. So they write a prescription, I take it to my pharmacy if I qualify, and I assume that's an income qualification.
No, it's just I'm going to check with people that it's just a patient
A patient of that,
patient
patient of that pharmacy or that FQHC of that hospital provider. The manufacturers are trying to interfere with that by saying the hospital has to dispense that.
Right, that it should be the covered entity's own pharmacy, but many covered entities do not have their own pharmacies, or may have a pharmacy on the site, but they don't have them out in the community.
So
Am I describing this accurately? Okay.
So
I've read some case law.
making it more difficult for people to avail themselves of these lower, and they'll probably do a cost benefit. I don't have a car. I can't afford to take the bus. And so I will pay the higher price.
So it's not the patient who is experiencing a different price. This is really about the acquisition by the pharmacy of the drugs.
So they will not deliver the drugs to my local pharmacy.
It just has to do with whether the pharmacy on behalf of the covered entity can acquire the drugs at the 340B pricing.
Okay.
The concept behind the 340B pricing being that
it goes to hospital.
That it goes to the providers, and this idea of savings or revenue, that is the difference between what they charge the payer and what they're able to acquire the drug for, allows them to invest, and the purpose of the program is to invest in other services for their patients.
Okay.
So that's what some of the reporting is.
Some have decided it is better to contract with a pharmacy. I guess the program for your patients, enhanced program, is they can afford their drugs if they use.
Again, it's not really about the patient purchasing that particular drug,
All right.
but the use of contract pharmacies allows the covered entities to kind of extend the reach of their 340B acquisition price.
So the pharmacy can acquire the drug at the 340B price if it is designated by the hospital.
They're under contract, right, and there's kind of a pass through of that discount
Okay,
back to the covered entity.
okay, this is saying you can't say no. This is saying that's okay to do.
Right. So this is effectively supporting the use of contract pharmacies by covered entities
Okay,
and saying the manufacturer can't get in the way of that. They can't make it more difficult for the covered entity to use a contract pharmacy. They can't prohibit it. They can't require extra things to be materials to be added or submitted in order to use the 340B pricing. Can't put limits on the pharmacy. And they can't do it. This last one is it has to be a discount at the time of purchase, not as a rebate. So not pay the higher price and then come back to the manufacturer for a rebate, but they have to honor the 340B price at the time of purchase, the purchase being from the manufacturer through the wholesaler.
Okay,
And can I just confirm with the covered entity folks that
They're all
I have
gone.
not said anything that is
Brainwashing them too.
nothing egregious has happened because they live in this world a lot more than I do. Okay. So then section 2 is all about reporting on this. So you are sort of aware of the 340B drug pricing program, but this is asking that the hospitals, not everyone who participates in it, so not the PhDs, but the hospitals specifically, would begin in section 2, submitting to the Green Mountain Care Board a report about their participation in the 340B program during the previous hospital fiscal year. And that report would go on the Green Mountain Care Board's, posted on the Green Mountain Care Board's website. So there's information about finding out the aggregated acquisition costs. So part of the program does not allow the covered entities to broadcast what the purchase price was. So they're going to provide the aggregated acquisition cost as well as the aggregated amount that they received for the drug. So what the payers paid them for those drugs. So you can get a sense kind of on the macro scale of what the difference is between the acquisition costs and the payment. And that the difference between those is the savings or the revenue, depending on your terminology. And then information reported separately in 4 different ways. So drugs that were distributed by being dispensed from an in-house pharmacy. So that's when the hospital has their own in-house pharmacy. Dispensed drugs from a contract pharmacy. So looking at the use of the 340B contract pharmacies. Administered drugs paid separately. So the drug was administered to the outpatient drug administered to the patient by the hospital employees, but billed specifically just for the drug, and then administered drugs that were paid by bundled payments because they were part of a larger group of services. And then it talks about how they would estimate the payment amount for administered drugs when the payment is bundled with payment for other services. They're also supposed to record the aggregated payment amount that the hospital wanted with contract pharmacies, so you can understand the role of the contract pharmacies in the financial picture. The aggregated amount that the hospital paid to any other outside vendor for managing, administering, or facilitating any aspect of its 340B drug program. A description of the way the hospital uses that revenue from its participation in the 340B program to benefit its community, which is what's required under the purpose of the 340B statute, through programs and services funded in whole or in part by revenue from that program, including services that support community access to care that the hospital could not continue without the revenue, and a description of the hospital's internal review and oversight of its participation in program, which is required to do under the federal government's program rules and guidance. It also, so all of that information will be posted publicly. And then in addition, there's a requirement that the hospital provide to the board a list of all of its outside vendors that managed, administered, or facilitated any part of the 340B program for them during the previous calendar year, and a brief description of the work performed by each vendor. And that information would not be public. That would be exempt from public inspection and copying under the Public Records Act and kept confidential, except for it will be provided to the Office of the Healthcare Advocate. They will not further disclose. All of that reporting in section 2 has a prospective repeal January 1st of 2031. So you'll get 5 years of reports, and you can decide if you want to keep going and get reports longer than that before the sunset. Section 4 is the repeal on, or the short-term repeal on the white bagging practice. So that is, again, under existing law, there's a prohibition on an insurer or pharmacy benefit manager requiring a pharmacy that it chooses to dispense a medication directly to a healthcare setting for a healthcare professional to administer to a patient. So there's the kind of administered drugs we're talking about. There's currently a prohibition on this idea of white bagging. This language in section 4 would repeal that prohibition. Section 5 would reinstate the prohibition in 2030. And section 6 would have the year before the Green Mountain Care Board, in consultation with DFR, report to this committee and House Healthcare Committee about the impact of the repeal on the ban on white bagging and what the impact has been on hospital budgets, on health insurance premiums, and on health insurer solvency. So temporary repeal of the ban on white bagging, report on what the impact has been of having that ban not in place, so allowing white bagging, or at least allowing negotiation for white bagging, and then putting the ban back on January 1st, 2030, unless you make a change prior to that. And the remainder of the act takes effect on passage, with the first hospital 340B reports due on or before January 31st of 2026.
Okay. So this is a new subchapter.
Yeah, new subchapter that I called 340B drug pricing program, with the potential that if we do other work on 340B under state law in the future, we could put it in that version.
Okay, questions for Jen? Okay. Does anybody know where our clerk has gone?
I have texted him and he has not gotten back to me, so I don't know. But I'm happy to, do something.
We need a deputy clerk.
Maybe secretaries could be
Deputy assistant clerk.
Deputy assistant.
Can we get a clerk?
Page. Got 2 clerk pages.
We need one. Well, you have to give 2 bills that.
Yeah. Who's clerking?
Senator.
Oh,
I
right.
moved sick.
I have a clerk. But we need a motion, right?
I need a motion. I need a date.
Sorry, I'll put it back up.
Draft
2.2. You should, it is drafted, but I can put it back.
So I should get time and date. Okay, I move approval of H266 draft 2. I need to move to amend. We have amended, right?
This is a strike all, so I
Strike
think
all.
you're maybe doing my understanding is you're doing one. My understanding is you're supposed to do 2 votes, one
Okay.
to amend the bill
and then
and the other
one.
to report the bill favorably as amended.
So I move to amend H266 as it came to us from the House with draft 2.2 dated 5/6/25 at 5:17 p.m.
And that could be a straw.
That could be a
right,
straw.
on the amendment.
That's how they do it in the house.
Yeah.
They do a straw poll.
Okay. So all those in favor of amending the draft?
Yeah, I just say aye.
Thumbs up or
Just say aye.
say aye. Aye.
Okay, now I move
And if he comes
approval
back, we'll let him
of
vote.
H 266 as amended
To the full Senate?
to the, yes,
Okay.
I don't know where it's going.
That's good. That's a good vote.
I think it goes there next, even if it has to
No
get
roads
referred.
in there.
Even if it has to get
No
referred.
fees.
I don't think so. I don't think there's anything. If there's any, none.
There's no apostrophe S's that are missing.
I hope not.
Okay, so we will take the vote on this draft.
Any discussion?
With any discussion.
Any discussion? Okay.
Page 266, draft 2.2.
Yes,
Senator Hart,
Yes.
Senator Gulick is yes, and Chair Lyons.
Yes. And this bill does have a ways to go back to the House. I think they might be wanting to modify it a little bit, so we'll see what they do with it.
very answered central.
Huh?
Yeah. Do we have Senator Cummings as the reporter?
I can do it.
Would you like to? Fine, that's good. All right, then Senator Douglas came in. See if you'd like to vote on it. 266 draft 2.2. 340B,
Sorry.
huh?
I was really sorry.
Who?
The principal. Bill.
Oh,
Sorry.
That's the principle.
See?
So, do you like,
The
what's your
principal
vote?
266?
Yeah,
Yes.
okay, so 5-0-0.
Senator Cummings has graciously
But that'll go up today. It'll be on notice.
Tuesday, up for third read Wednesday.
For second reading.
Yes.
Second reading on Wednesday.
I remember you always got backup, so.
Then you, and I can get you a second. I think I had one for the. Oh,
Okay, that would.
yes.
Okay, we also have 482 to look at. Do we have anything new on 482?
No, I just took out the highlighting. So it's a clean copy of what we looked at on. Whatever day it was earlier this week.
Let's look at that together.
I made it 1.3, but it's just.
What draft is it?
It's 1.3. It's a clean
1.3.
version of 1.2. So if somebody still has one, that also works.
I know the healthcare act, which will have a couple sentences if wanted. That get
Yeah, so you hear.
okay.
I've been
That's in.
No, that is not in
That is not.
So we might hold this, until we do hear from it, because I know he has something. You see what happens.
Okay.
Yeah, do you know what exactly I sort of know? Not my offer, so I can't say what it is.
It's language that was considered in House Healthcare and then taken out as well.
Okay.
In one process. Doesn't mean you
Yeah,
can't.
he's a
put it
little
in, but
late
it
on
is.
that one, so let's just go ahead with what we have here.
All right, so this is H 482, an act relating to Green Mountain Care Board authority to adjust a hospital's reimbursement rates and to appoint a hospital observer. Thank you. Section 1 is the section on reduction or reallocation of reimbursement rates and risks to health insurer solvency. We have definitions of hospital and hospital network. These are the same definitions we've been looking at in various places, including S126 and this bill. So this language says if the Green Mountain Care Board determines after consultation with the Commissioner of Financial Regulation that a domestic health insurer faces an acute and immediate threat to its solvency because its risk-based capital level has triggered a regulatory action level event pursuant to APSA 8304. The board may order a reduction of the insurer's reimbursement rates to one or more Vermont hospitals as set forth in subsection C until such time as the amount of the insurer's risk-based capital exceeds the company action level risk-based capital threshold defined in APSA 8301 and specifies that notwithstanding any provision of The Administrative Procedures Act to the contrary, the board's activities under this section shall not be construed to be a contested case. Any person aggrieved by a final board action, order, or determination under this section may appeal as set forth in section 9381, which is the board's appeal statute. Else, it says the board shall only order a reduction in the reimbursement rates to a hospital that meets one or both of the following criteria. The hospital has more than 135 days cash on hand and had a positive operating margin in the previous fiscal year. Or the hospital is a member of a hospital network that at the consolidated network level has more than 135 days cash on hand or had a positive operating margin in the previous fiscal year, or both. Specifies that the board shall order a reduction in reimbursement rates to a hospital only to the extent necessary to remediate the threat to the domestic health insurer solvency. And in determining whether and to what extent to reduce a hospital's reimbursement rates under this section, the board shall consider the competing financial obligations of the hospital and of the domestic health insurer. Requires the board to provide a hospital with the opportunity to request relief from a rate reduction order pursuant to this section, and specifies that in no event shall a reduction ordered by the board result in a decrease to hospitals or hospital networks projected days cash on hand to below 125 days. Section 2 is the some amendments to the Green Mountain Care Board budget review statute. The first in establishing individual hospital budgets. Budgets must reflect budget performances for prior years, and then this would add, and if not already addressed pursuant to subsection H, which is the enforcement section, account for any significant deviation in revenue during the most recently completed fiscal year in excess of the budget established for the hospital pursuant to this section. In subsection F, it adds new language allowing the board on its own initiative to adjust the commercial health insurance reimbursement rates payable to a hospital at any time during the hospital's fiscal year in order to ensure the hospital operates within the budget established under this section. And subdivision G2 allows the board, upon finding that hospital has made a material misrepresentation in information or documents provided to the board, or that it is materially non-compliant with the budget established by the board, appoint an independent observer with respect to any matter related to the board's review or enforcement under the section if the board believes that doing so is in the public interest. Specifies that the independent observer shall be a person with experience and expertise relevant to the specific circumstances. And at the direction of the board, the independent observer may monitor the hospital's operations, obtain information from the hospital, and report findings and recommendations to the board. An independent observer appointed pursuant to this subdivision has the right to receive copies of all materials related to the board's review under this hospital budget review section, and the hospital shall provide any information requested by the observer, including any information about the hospital's participation in a hospital network. The observer shall share information provided by the hospital with the board and the Office of the Healthcare Advocate, but shall not otherwise disclose any confidential or proprietary information that the observer obtained from the hospital. The board may order a hospital to pay for all or a portion of the costs of an independent observer appointed for the hospital pursuant to this subdivision. Section 3, the authority to appoint the independent observer is repealed on January 1st, 2030. So that's in place for a limited period of time unless you go back and change that date and the act is effective on passage.
Okay. Jimmy, I would feel more comfortable reporting this one. Unless you want to do it. You're gonna do it. I thought you would, but
I got you. Just, if you don't want to do 340B, we can talk about how to do that.
I'm just comfortable with
So I know we're out of time.
So let's talk about this bill,
Okay.
because we're getting clinked upstairs.
Yeah.
So is there anyone resistant to voting on the bill at this time?
Voting on it right now?
Yeah,
Oh,
I said, are you resistant?
sorry.
Right now, are you resistant?
We can vote on that. That's what you want to do.
Great.
Or we could talk to Mike first.
Well, I mean, that's a little penny wise, it's a little late, I'm sorry, and I understand that you presented it in the House what is the language that you want to present? I'll give you 1 minute. Half a minute.
So this would be language to give the board the authority, not require them to, but give them the authority to update their hospital budget guidance for 2026.
Okay, that's a longer conversation. We cannot do that right now. It's a long time, so we'll just go ahead here with the vote. And that's an issue that may well be taken up at another time in another bill. I understand that.
I can make a motion.
You sure
And
can.
I will make a motion to pass favorably draft Article 1.3 of H 482 from the Senate on Welfare Committee.
We struck it out. Was a strike all.
Yeah.
So, so the first motion is to pass it as amendments to amend.
First motion is to amend for H 42, the draft of number 1.3 of 5/9/25 at 7:32 a.m. That's when it was done. That was early, John, early in the morning.
You got.
Too early.
And that this can be a straw poll for the amendment. Aye.
Oh,
All in favor?
Aye. And now I'll make a motion for the bill itself, which is draft number 1.3 of H 482.
Go ahead.
discussion.
Discussion.
Enter discussion.
No discussion. Okay, go ahead.
Discussion.
Sorry.
Senator Cummings,
Yes.
Senator Douglas, no. Senator Bueller,
Yes.
Senator Harvey, no. Senator Lyons.
Yes. And you're,
And you're.
yeah, I am. Okay.
What were you?
He was a no. Your concern is the critical access hospitals, I think.
Yeah, I have several of those in Florida,
Yeah, I
yes.
got you. So, but that's the end of that conversation.
Yeah, okay.
We are done.
Um,
Okay.
That's